get started, I'd like to introduce Dr. Shevanthi Nayagam, who's a clinical academic and honorary consultant hepatologist at the Imperial College in London. Shevanthi co-leads the Imperial College Viral Hepatitis Applied Modeling Group, and is also a member of the Prolifica team, and has worked with many countries to support their national hepatitis strategies. We're very excited to hear Shevanthi's presentation, so I'll turn it over to her at this point. Shevanthi.
Thanks very much for the introduction, John. I'm just trying to share my screen. Can you see my slides?
Right, can you? Yes, perfect.
Yes, okay, great. Thank you very much for inviting me to speak at this great forum, and it's a pleasure to be with you all. So I'm going to talk a bit about modelling to inform hepatitis B birth dose implementation, sort of taking it from a global level and giving some country examples about where we're really at with birth dose and where we need to go. So just a reminder what applied modelling can be used for and when it can be used to inform public health policy. So I sort of think of it as modelling provides a means by which different data types can be combined together under strictly defined rules and can be used in a variety of ways. Now, the thing that I always caveat this with is modelling does not replace empirical data. So the better the empirical data, the more robust the model projections can be. So this is sometimes something we come across a lot in hepatitis B because of the lack of data that we, have higher uncertainty. So some examples of the use of modelling in hepatitis. So of course, we've seen that it can be used for target setting, for example, the WHO elimination targets. It can be used to support development of national hepatitis action plans and to guide strategy planning. And that, I know, our group, the Polaris group, other groups have been doing that quite a lot with different countries around the world. In our case, for example, we supported Senegal, China, South Africa, a few other countries sort of try and inform their national hepatitis strategy. It can be used to evaluate the impact of interventions and guide investment strategies. For example, through the Vaccine Impact Modelling Consortium, we use 2 different models to guide some of the investment strategies. And it can be used to guide validation of elimination. So we've got this elimination, but how are countries on track and are they progressing towards elimination? That can combine empirical data and modelling as well. And of course, many of you are familiar with models are used to develop burden estimates. For example, the Polaris collaborators use models to combine prevalence estimates and define a burden. So back to hepatitis B mother-to-child transmission, which I think I won't dwell on this slide too much because I think everyone's summarized it nicely. So 3 reasons I put forward why hepatitis B mother-to-child transmission is important. Of course, the first one is the risk of developing chronic infection is higher if infected perinatally. Secondly, often people think that mother-to-child transmission isn't significant or it's mainly a problem in Asia. But what we found is that because of the successes of infant vaccination in interrupting horizontal transmission, actually, mother-to-child transmission is becoming a predominant mode of ongoing transmission. And this sort of figure on the top right hand shows that even though all transmission is falling, the residual new infections are mother-to-child. And therefore, it is an important means if we want to reach elimination. Then the third reason, which people have touched on as well, is that perinatal infection is thought to lead to more severe liver disease progression. So this is a figure looking at the global scale-up of hepatitis B interventions. So the year on the x-axis and the new cases of chronic hepatitis B infection averted in the y-axis. And what we're showing is that status quo, which is the blue line there, we're already going to get a decrease globally because of infant vaccination. But what's going to have the biggest incremental impact, in addition, is to scale up hepatitis B birth dose interventions. And this is really what we're going to concentrate on today. But this was back at 2015, using data from back then, using intervention coverage back then. And we had the elimination targets that were adopted more than 5 years ago. So we're less than 10 years from 2030. Where are we at now, and what impact could the birth dose have now? So here we took, we developed country-specific models for 110 low and middle income countries. So this actually encompasses about 92% of the global hepatitis B positive people, and includes all Gavi-funded countries, and included the latest coverage of interventions and calibrated country level data now rather than regional level data with the previous model on burden. So from Polaris, from WHO estimates, and IHME cancer deaths. And what we did was we evaluated the impact of scaling TBD, so I'm going to use that as timely birth dose vaccination, to 90% from, well, it's not now anymore, but from 2019. And what you can see is that overall, by birth cohort, about 770,000 deaths will be prevented by scaling up hepatitis B birth dose. And then if you look at the panel on the right, when you see the birth cohort on the x-axis and the deaths averted in thousands on the y-axis, we break it down by region. And what you can see is the majority of the deaths averted by scaling up hepatitis B birth dose vaccination is in the WHO Afro region. Now this is because the burden is high, the baseline coverage of hepatitis B birth dose is the lowest. And of course, there's also incremental impact, particularly in the Sero and EMRO regions. So really, we can still achieve quite a lot if we scale up timely birth dose now. And then if we look in a bit further, this figure, this map shows the percentage of the overall global hepatitis B deaths averted by this 90% scale up. The darker the color, the higher the contribution this country has. And what we can see is, of course, the Afro region, which reflects the graph before, but here about 26% of deaths averted globally would be in Nigeria. This is reflective of population size, burden of disease, and lower levels of hepatitis B birth dose. So this is what drives the impact that a timely birth dose could have. Then what would the impact of timely birth dose be in prevalence of 5-year-old children? Now, historically, there was the 90% reduction in incidence, but of course, 90% reduction is very difficult to measure. So WHO are talking about an absolute target of 0.1% prevalence in 5-year-olds. And what we can see is globally, 90% scale up, which is the red line compared to the status quo, would get us quite far nearly all the way to 0.1%, but not by 2030. But more interestingly, when you break down by region, you can see that it's highly heterogeneous. When different regions will reach this WHO 0.1% prevalence target will vary. And just to remember that this modelling aggregates 110 countries, which are the high burden countries. It doesn't aggregate the high income, low burden countries. So for example, Euro might achieve it sooner if you include all the countries. So what I'd like to draw attention to here is that in the WHO Afro region, at status quo, that 0.1% prevalence would not be reached before 2100. But by scaling up timely birth dose to 90%, it won't be reached by 2030 because the baseline is higher, but it will be reached just before 2060. So really there's massive progress towards this absolute target that can be made in all world regions and particularly in the WHO Afro region. Now, of course, I'm just going to put 2 slides on this, the impact of COVID-19 disruptions. We know that, 2020 has been a difficult year and this is not the end of it. And the figure here on the left shows a WHO pulse survey looking at disruptions to essential health services during the pandemic. This was last year. And what we can see is antenatal care, facility-based birth, immunizations, including outreach activities, have all been disrupted. How much and how long-standing this disruption will be is still yet to be determined. But what we did do was try and evaluate the impact of theoretical drops in timely birth dose coverage in 2020. So say, what would happen with this temporary disruption? And because we don't have primary data or the time to parameterize these drops in timely birth dose coverage, we explored a few scenarios, which is the benefit of model. We can just explore to see what could happen. And on the x-axis, we've got a 5% drop, 10%, 15 and 20% drop. And what you can see is if there was a 20% drop in 2020 coverage levels, there'll be about 17,000 additional deaths. And that impact would be mainly in the 2020 birth cohort, which makes sense if it's a temporary disruption. And the largest number of additional deaths would be seen in the Western Pacific and Sero regions, which have high burdens, but also have a baseline higher level of birth dose coverage. Now that was looking at temporary drops in coverage, but what about if birth dose scale up was delayed, which might happen because of other priorities, funding disruptions. So here we're comparing scale up to the aspirational 90%. So we're comparing delays to the aspirational 90% scale up. And what we can see here is that delays in scale up, and on the right panel, which I've just highlighted here, where we delay scale up for 5 years, and then we reach the 90% coverage by 2040, could lead to about 630,000 avoidable deaths globally in the 2020 to 2030 birth cohort. Even if timely birth dose scale up has only a 3-year delay and we try and catch up to 90% more quickly, so by 2030, this still has a significant number of avoidable deaths. And what we see here, because the Afro region has the most to benefit from the TBD scale up, this would be the region now that would be most affected. So that's a bit of sort of the global hepatitis B birth dose coverage strategies. And I'm just going to talk a couple of things about modelling to support national policy planning. And here we're just given a case of China, where we've used modelling and worked with WHO China and China CDC, both on treatment and prevention interventions. As you know, China's high coverage of vaccination, but at the time of this investment case originally, treatment coverage for those chronically infected was low. And what they wanted to know was, is it worth the impact and the cost to scale up treatment and do a comprehensive package of prevention and treatment interventions? And what we found was that actually this comprehensive package could avert more than 2 million deaths by 2030. And it's likely to be cost saving. So for every $1.50 in, $1 in, you get $1.50 back. And this is because the money you're putting into treating people now is averting the costs of management of end-stage liver disease, cirrhosis, and all the societal costs down the line. And there was some national policy change. There was a reduction in prices of drugs, including tenofovir, which was added to the reimbursable drug list. And this informed the 2017 National Action Plan for Viral Hepatitis. Then they went on further to say, well, because we've had high coverage of infant and birth dose vaccination interventions since the 1980s, through many things, including abolishing fees, funding support from Gavi, increased hospital births, they wanted to see how far could they get in elimination to reach this 0.1% prevalence target. Now, China have performed large nationally representative serosurveys, and they've documented the decline empirically in under 5-year-old prevalence from nearly 10% in 1992 to 0.32% in 2014. And we incorporated data on the prevalence, the intervention coverage, and found that actually at status quo levels, which is very high levels of birth dose, infant vaccination, and HBIG, China has projected to achieve elimination of this and reach this 0.1% target before 2030. So it's just sort of to demonstrate that it is possible even in a high burden country, but it does need a comprehensive evaluation and data and political will. This is just an example from that Hecht and some of the collaborators on the meeting now will recognize this work, where we used modeling, so hepatitis B and C modeling, to inform a hepatitis investment case for South Africa National Hepatitis Action Plan. And here, different hepatitis B and C prevention and treatment interventions were modeled, were costed quite comprehensively by the team. And just to highlight that birth dose vaccination was found to be a very low cost, cost-effective intervention to implement. Now, one of the problems, of course, is the data to inform modelling of impact of not just the timely birth dose, but any intervention. And specifically for timely birth dose, what is useful is nationally representative burden estimates, particularly in children and in pregnant women. And unfortunately, we know that some of those data sources are lacking in many countries. Although yesterday we saw some great examples of where this sort of data is becoming more and more available. And the figure, the panel on the right is just some, is an analysis that one of our PhD students did, looking at the different well-recognized hepatitis B burden estimates that we refer to, which is the IHME, the Schweizer Systematic Review, WHO estimates, and the CDA estimates, and really just showing that for both all age and under 5-year-old prevalence, there's a lot of uncertainty. The green dots are the WHO Afro region, and there you can see there's a lot of variation in the prevalence estimates. So if you've got the uncertainty in the data, of course, the modelling estimates are going to be more uncertain. Then, of course, it's useful to know the proportion of hepatitis B positive women who have HBe antigen high viral load, so representing high infectivity risk. And then this was touched on a lot yesterday about intervention efficacy. A lot of the data is often taken from Asia, but there's only limited studies about TBD efficacy in the Afro region. And there's a question that maybe it's not as effective, but again, more data on that will help inform the projections. And of course, there's the costs of implementing these different birth dose strategies. So the model of birth dose intervention will vary by country. Certain countries will need a more outreach component. Certain countries will have higher facility births. And this really needs country level planning and local level costs, depending on the demography, health seeking behavior, and the healthcare structure. So I think I'm out of time now. So in summary, really, we're less than 10 years away from the 2030 targets, and the coverage of timely birth dose remains suboptimal. But it's not all negative. Scaling up timely birth dose to 90% will have a large impact, and the greatest benefit will be seen in the WHO Afro region. However, with birth dose alone, the WHO target of 0.1% prevalence for 5-year-olds is unlikely to be reached by 2030 in a global level, because we've moved forward, yet moved on 5 years, yet not necessarily progressed the agenda a lot. COVID-related disruptions to timely birth dose, including drops in coverage and delays in scale-up, will lead to a substantial number of avertible hepatitis B infection and death. And modelling can be a useful tool to guide local policy planning and inform implementation of these TBD strategies. Although it does have its limitations, And therefore, systems really need to be strengthened for collecting nationally representative data. And what I think is the more granular the data, the more robust any projections, any planning can really be. So that's it. I'd like to thank collaborators all over the world, and I'm happy to take any questions.
Thank you so much, Shevanthi. You will be getting some questions in our discussion period. That was a great overview. Really shows the importance of having targets to begin with, so you can really monitor your progress. And a lot of progress is being made, and it does show you the power of hepatitis B birth dose implementation. And